like to invite Dr. Colon-Franco to the stage.
Thank you for the introduction, and thank you all of you for joining us this morning. It's very special for me to be speaking today with Leslie about this work, because we've been working on it for about 3 years or so. So it's only natural that we stand here together to tell you more about our journey. We work in a clinical laboratory, and that's our context and the context of the testosterone testing that we do. So we're going to talk about the clinical regulation of testosterone, the analytical variability, and how we've used that to design both a total testosterone assay and a free testosterone assay using direct equilibrium dialysis testing. We're going to start talking about testosterone regulation. Again, there's a lot of aspects that impact testosterone concentration and levels, and that added and compounded into the analytical challenges that we have. But testosterone is regulated by the hypothalamus pituitary axis, and in men, that is the main mechanism for contributing to testosterone levels. In women, however, about 50% is regulated through that pathway and 50% is contributed from the adrenal glands, either direct testosterone or through the precursor androstenedione. But throughout the lifespan of a woman transitioning into the postmenopausal stage, the production by the ovaries decreases. Other layers of regulation for testosterone include the variability through the age. Both men and women see a peak in right after puberty, and then a decrease around 30 or 40 years of age. Keeping in mind that the concentrations that we're displaying for men are in nanograms and for women are in picograms. So that's important. In addition to that, there's circadian rhythm, so testosterone will peak in the morning, but that rhythm is lost in older men, where you don't see the drastic peak in the morning. Food intake or glucose intake suppresses testosterone concentrations. And last but not least, in circulation, we find testosterone in different forms. So the free form, known as the active form, is in circulation represented about 2 to 3% of the total testosterone. And then there's the bound forms to either albumin or sex hormone binding globulin. So about a third is bound to albumin, and the rest tightly bound to sex hormone binding globulin. And the portion known as bioavailable testosterone is the portion that is free or loosely bound to albumin. Taking all these together, there's a lot of a large difference in the concentrations of testosterone in both children and men, the corresponding adult cisgender for boys, or for girls and women. And if you notice, this is a log scale, so the concentrations between women and men, adults, it's several log differences. And this is important in terms of the assays that we want to use to measure, and the robustness of the assays, and what we need at low concentrations and so on. So notice here that we are aiming at concentrations close to 1 nanograms per deciliter to meet the need of measuring testosterone in pediatric patients. There are several indications for measuring testosterone. It's heavily ordered in the laboratory. Perhaps the top ones are the ones that that are more predominant, which is hypogonadism in men and hyperandrogenism in women, linked to conditions like polycystic ovarian syndrome. These are highly prevalent in our population, but it's hard to assess as well due to the variability in definitions, testing measurements, and so on. For example, there's different studies for hypogonadism that would state a prevalence of 2%, and then there's studies that, depending on the population and the definition of hypogonadism, goes up to 30% in men after 60 years old. There's also a lot of conditions, both in men and women, including fertility evaluation, congenital adrenal hyperplasia, and monitoring either androgen suppression or replacement therapy in men or testosterone replacement therapy in women, most commonly and most recently in menopause. There's a lot of buzz and articles and research about the role of testosterone in many other metabolic diseases. However, there's no true indications for testing for any of these conditions. So when we think about all these contexts of in health, in disease, and what the guidelines say, I'm not going over specific guidelines for any disease state in terms of sort of summarizing what in general guidelines say about the measurement of testosterone. So there's a couple things that they pinpoint in terms of the biochemical assessment of the androgen concentration. Number one is to use an accurate and reliable assay, and they would state that preferably one that is monitored or assessed or certified by an accuracy-based program, such as the CDC Hormone Standardization Program. They also state to assess free testosterone when needed, and there's one main condition. It's the alteration of sex hormone binding globulin or borderline total testosterone, and to determine free testosterone either by equilibrium dialysis, which is recognized as the gold standard, but they also include the possibility of using calculations which include total testosterone, albumin, and sex hormone binding globulin, and they don't prescribe one specific calculation. And to avoid direct analog measurement using immunoassays or calculations like the free androgen index. They also recommend to test in the morning and fasting, and to avoid testing in conditions that can affect testosterone, like acute illness, or in situations where the patients are taking drugs or medications that can affect or suppress testosterone, like corticosteroids, for example. And to interpret using a reference interval that is derived for that specific assay. And they highlight this because of the recognition that there's a lot of assay variability and poor standardization across assays, and really no universal cutoff established. So recapping what we would like for a testosterone assay, in this diagram we see that there's, again, large differences in the concentrations that we want to measure in adult, healthy male and female. So we want an accuracy over a wide measurement range, but we also want to be able to assess disease. So whether it's elevated testosterone in women, decreased testosterone in men, and then you start seeing that there's overlap in the concentrations, or replacement therapy, which typically targets the normal reference range. So we're asking a lot of from these assays, from accuracy, sensitivity, specificity, and so on. And we accomplish this and the kind of volumes and requests that we get for this test by using a variety of assays. And these include both immunoassays and mass spectrometry assays. So this is a representation of the volumes in our laboratory over month, and this is 1,500 tests a month, so just for reference. So you can see that we offer total testosterone by immunoassay, and that is our highly most ordered test, followed by testosterone, total and free, by either, by mass spec, equilibrium dialysis, and at different times we've used reference lab that offer ultrafiltration and so on. We also calculate free and bioavailable testosterone by immunoassay, which is represented here in green, and also offer total testosterone by mass spec on its own without free, which is represented here in this line. So again, we offer a diverse menu. It could be more extended, it could be more restricted, but this is where we are at right now. These are very high volumes to accomplish in a laboratory testing. The immunoassay tests are fully automated, open access, and that's how we can really serve our orders of testosterone, is by offering immunoassay. However, immunoassays have limitations, and I think this audience is very aware of those limitations, but they seem to perform optimally in men, in adult men, where the concentrations are typically higher. And this has been demonstrated whether you use a reference standard material and you check the recovery of different immunoassays, or if you compare to mass spec as a reference method, you see adequate performance in men. However, in female concentrations, you see that it does not perform as well, whether it's by comparing to a reference material or by comparing to mass spec, where depending on the assay, you may see a bias of from 15% to almost 70%. What about mass spec assays? Going back to over a decade ago, we recognized the superiority of mass spec, especially for sensitivity and to measure at very low concentrations. But inter-laboratory comparison studies demonstrated that even using mass spec, depending on the calibration that you use, the method, the sample preparation, and so on, you would see biases relative to a method in this case. And these are more highlighted or larger at low concentrations under 100 nanograms per deciliter, which are the concentrations that we will emphasize in the measurement of testosterone in female and children. So this highlighted the critical need for standardization, and over the next years, there were efforts and a program that the CDC created with other collaborators to create a reference measurement procedure for testosterone, and simultaneously there was a development of performance criteria using biological variability as the base, so we could anchor on something. So now we have a reference method procedure to anchor on, and a program that would be available for laboratories, as well as standardized performance criteria to assess how good or how accurate or precise your assay is. Fast forwarding to this year, this is a screenshot of a recent CAP survey. There's no recent publications assessing current immunoassays, although some of them are fairly similar to what we saw in the publication from 2019. You can see, for example, for one sample, which has lower concentrations of testosterone, that you still see significant variability across assays. Mass spec is also listed here. So you see that there's still variability, and both across assays and within assays across laboratories. So these problems at the low end still persist for immunoassays. So the standardization efforts have really impacted mass spectrometry assays much more so than immunoassays. So there are several published methods that have demonstrated that the standardization and harmonization of tandem mass spec assays is possible, thanks to the availability of the RMPs, certified reference material, the standardization program, as well as accuracy-based proficiency testing. And this had an impact on demonstrating that harmonization is possible, increased the accuracy and reliability of the assays, and has made feasible, for example, to harmonize reference intervals mostly for men. This is a series of papers that demonstrate this, and it's not an all-inclusive list. So that's great news. So with that in mind, we thought we could undertake the task of developing a total testosterone assay using all the foundation that is out there in the literature. We do have certain challenges that were our own. So this is a very high volume test in our institution, and it's coordinated with free testosterone. So when we approach developing total testosterone and the analytical complexities, we had in mind that we had to also offer free testosterone testing. It was our sixth highest send-out cost testing, and we are a hospital laboratory setting with a limited number of tandem mass spec with limited automation and technical expertise. So our ask for the development resource that would work on this was to develop a high-quality assay, but to work on it, to repurpose it for using it for direct free testosterone measurement. And then a third desired outcome in our institution was to improve the utilization of total and free testosterone assay. We're not gonna talk about that, and this is a reference to a poster that we had in blogs on this topic. With that, we are gonna transition to Leslie's part for total testosterone.
Hi, my name is Leslie. I was asked, in my naivety, didn't think it was that big of a deal. Just, make a total testo assay that we can then springboard off of into free. So we knew we were going to have a high sample throughput. We're anticipating 400 to 500 samples weekly. We needed a dynamic measurement range. This would reduce the amount of repeats on the bench. And I really feel like my manufacturing background, I've always got that running in the back of my head. How can we improve this process and streamline it, make it easier? And we wanted a straightforward extraction. So we encountered several challenges along the way from total testo. High background is always something we battle in mass spec. This is an example of the water that we were using. So we did an initial blank injection here, and that's highlighted in green, and then we had a high equilibrium with the aqueous mobile phase. And as you can see, the highlighted red box is the expected retention time of testo, and this is our neat solution of 10 nanograms per deciliter. So this gradient with this mobile phase setup wasn't going to work, because if we're not seeing this in neat solution, we're definitely not going to see this in matrix. So once we hurdled the mobile phase issue by using LCMS grade bottled water, we had to tackle the low sensitivity. So once we tamped down the baseline, we looked into mobile phase additives, sample prep. We did explore protein precipitation early on, but we realized we're not going to be able to get a clean enough extract or supernatant to use for free. We did evaluate several SPE products, but there's a lot of rinsing and washing steps, and these are increased chances to contaminate. So we really wanted to remove as many solutions as we could just to keep the process streamlined and keep everything clean. So we landed on liquid-liquid extraction, which we then eventually moved to SLE. And this diagram here just shows you the signal gains that we were able to achieve with ammonium fluoride. So this is a very small amount of ammonium fluoride. We're using 2 millimolar, and we were able to see a 3x signal improvement. So we also experienced issues with sample bias, like anything with mass spec. Our calibrator matrix, you can use solvent-based matrices, synthetic matrix, and you can even use patient pool. The endogenous nature of this analyte makes it very difficult to find a truly blank matrix. So we ended up using a stripped serum because we were able to get minimal matrix effects with that, but also be in line with more of a patient sample. We also examined our calibrator prep, and I have some examples of pre and post optimization of that process. So pre-optimization, we were comparing our in-house spiked curve to commercial calibrators. Whenever we have the option, I would prefer to prepare things in-house. You have a lot more control over the the reference material that you're using, in addition to the process and how you're aliquoting. You can make more or less depending on the stability of the products. So here we can see we have a high sample bias with our N-spiked curve versus commercial calibrators. So using the NEAST standard reference material, which is available through NEAST, we were able to look at our calibrator prep and use different carrier solvents to dilute our reference material in, and then really focused on integrating the analyte into the matrix during the high-level sample prep, so the serial dilutions or subsequent dilutions perform better. So with our amended prep, you can see that we have much better recoveries compared to the commercial calibrators, and yeah, thank you, NEAST. So development scale-up. We landed on liquid-liquid. We knew that that extraction worked, but for the throughput that we were expecting and just the tech time, it's not really feasible. I was using a pour-over method in culture tubes, and that's just a lot of transfer, a lot of labeling, and every time somebody touches something, and something that's in the back of my mind is, we can contaminate something. Like, the more touch time, typically you want to reduce that because it will reduce errors. So we moved towards supported liquid extraction. I started development with cartridges, small scale, and then we moved up to plates because we knew we were going to get that sample volume of approximately 100 samples a day. And shock, we now experience a new challenge. So why is my signal gone? Everything looked great when it was in cartridges, and we go to the plate, and now we have an issue. So after multiple meetings and spreadsheets, we were able to determine that this was due to the collection vessel. So steroids have high affinity for plastics and different laboratory, just labware in general. So the mitigating resolution for this was that we were able to collect our eluent into glass-coated collection plates. So those are a little bit more expensive, but you're not going to sacrifice losing any of your analyte or sensitivity. Another big challenge for testo and any endogenous analyte are interference. I'm going to go over a couple here. This is a native interferent, androstenedione. So the chromatograph that you're looking at here has a peak that is integrated at the retention time of testosterone, which I was not expecting because this was blank matrix. So after some mild panic and going to my supervisor, who was able to calm me down, we took a look at the C of A. And through examination of this, we were able to see that there was noted and reported a small percentage of testosterone within that reference material. So we were able to use that to determine the root cause of that peak in the blank. Additional interference, this is non-native. This is bupivacaine. I was not expecting to see this. This interferent was in one of the cerulean interference mixes that they offer. You see there's like a large blobby peak, and then there's no confirming ion here. So I was confused. You know, I went through all of the molecular weights. I didn't see anything in these mixes that was isobaric. As you can see, the weight listed was 342 and testo was 288. So I was confused about that, but as you can probably see, and this is also probably my naivety, it's an HCl monohydrate. So that is adding additional atomic mass. So looking into the C of A, they do provide different spectra. We're able to see in the mass spectra that there is indeed a peak there, and that is isobaric with testosterone. So now this is a known interferent, and then this is just documented in our SOP. And it's very obvious that this is not a peak. We also experience interference with collection tubes. This is a snip from Deb French's paper in 2013. This is her 4 nanogram per deciliter testo peak. And this is the same concentration extracted from a sample collected in a serum separator tube. Here we can see the gradient separating out the interference from the testo peak, which is great. But it's just something to be aware of when you're collecting samples. We use red top serum. to avoid this, but every once in a while you'll get something that's collected in the wrong tube, and we actually did additional studies with different serum separator tubes because we were having issues finding a healthy population to draw from for our reference interval. So we went ahead and did these tube type comparisons just to increase the pool that we could draw on for healthy individuals. This is an overlay. The black trace is from the red top serum, and then the red trace is from the serum separator tube, and we are also separating out that interferent. So after we've hurdled all these issues, we reached out to the CDC to participate in their phase 1 hormone standardization program. We were able to run all 40 of their samples and report data with great correlation and a very low bias. So I was very proud of this. We worked really hard to get the total testo running, and this is just a summary of our validation performance. We were able to achieve our dynamic range from 1 to 2,000. I think to date, since we've been live, there's only been a handful of repeats due to being over the AMR, which is really nice for the bench workflow that they're not having to continually repeat samples. A very low carryover with this method in the wash after the end of the gradient, and we have really good signal for our LOQ. And we compared, again, with a reference lab with a bias of 2.8, and that is separate from the CDC. So I will give it back to Jessica.
So to summarize this part, the commercial for total testosterone, the commercial available testosterone assays still have limitations for which we have to have tandem mass spec methods in our laboratory, and there's a good foundation of tools and methods published, but it doesn't come without challenges, as Leslie presented and demonstrated to us. Now transitioning to talk about what we are all here to talk about, which is free testosterone. So total testosterone seems to be unreliable in certain clinical contexts, particularly in contexts where the levels of sex hormone binding globulin vary, or there's displacement of testosterone in this case by either free fatty acids or drugs. The clinical relevance of testosterone is somewhat well understood and established, and also somewhat controversial and not well understood. Starting with the free hormone hypothesis that states and postulates that the free active form of a hormone is the one that has the biological active capabilities, because can go into the cells and so on, whereas the bound forms cannot. Free testosterone is recommended by most guidelines, whether preemptively or with the quote-unquote of in conditions where sex hormone binding globulin is affected, or borderline testosterone concentrations. The evidence exists to make a point for the superiority of free testosterone, particularly in studies that have shown that free testosterone concentrations, but not total testosterone concentration, is associated with the symptoms of hypogonadism in men, but also with the metabolic disturbances in women with PCOS, whereas total testosterone was enough to correlate with the ovarian disturbances. However, because of the limitations of free testosterone assays, it's still recommended for PCOS assessment to, for example, lean more on total testosterone than free testosterone, because there's a lot of limitations of the assays. So when to measure free testosterone? When there's decreased sex hormone binding globulin, increased sex hormone binding globulin. The conditions that affect these are not necessarily exclusive and very easy to parse out in the typical population in which we measure testosterone. So to come up with an algorithm where you can operationalize whether it's at the clinician level or at the laboratory level to make a decision to measure or not free testosterone is not as easy as straightforward, and that's why we land with a lot of co-orders of total and free testosterone. as I mentioned early on, there's direct measurement and estimation, and they're equally sort of mentioned in the guidelines, making the note that the gold standard is equilibrium dialysis. There are other approaches to separate the total and the bound and the free forms of testosterone that are may also be feasible, also complex, analytically speaking, and naturally an estimation tends to be more straightforward. That is widely recognized, and these calculations include total testo, sex hormone binding globulin, and albumin. And there's also two lines of testing, or two divergent types of or groups of equations. The ones that assume there's a linear binding model in the relationship of total testosterone and free testosterone, and that includes equations like the ones that we very commonly use in our laboratories, the Vermeulen equation, or the most recent allosteric models that would state and recognize that sex hormone binding globulin is dimeric and bind two testosterone molecules, and the binding of the first one impacts the binding of the second one, and takes all that into account for a more accurate estimation of testosterone, free testosterone. We can recognize that equilibrium dialysis is the gold standard. That is great, but that comes with a lot of analytical challenges. We can also recognize that calculations are more practical, but there's also no consensus about what represents an accurate measurement or an accurate calculation or estimation due to the lack of a reference method and standardization of these assays. I want to go back now to 2019, where I took a look at the CAP proficiency testing results for free testosterone, and you can see that for all methods, regardless of the method, there's a large variability in the measurements of free testosterone. A little bit less for bioavailable testosterone, but still around 20 to 25%. And this is attributed to many things: the differences in methods, the difference in formulas, and so on, and the different approaches, and obviously the difference in calibration standard. The CDC has put work and effort into a standardization initiative. It's not expected that it's going to be like the standardization program for total testosterone. Nonetheless, they've developed a reference method using equilibrium dialysis and isotope dilution, mass spec, using a certified reference standard. They have reported the performance of this assay in an abstract in a conference, so you can see that it can go as low as 2 picograms per mil with high precision and accuracy. And the initial goals of their program is to assess where are we at, and assess where the free testo assays are at, identify the sources of variabilities, and provide support for manufacturers and laboratories to improve the assays. They've also presented the preliminary findings in the abstract that is referenced here, and they found high variability across the participating free testo assays, both direct measurement and calculated. So our asks for this assay are very similar to the asks for the total testosterone assay in terms of the volume and the throughput, with added layers of, now we're talking about picogram concentrations and demanding analytical sample requirements. So we had a revised goal, not only to develop a high quality assay repurposing total testosterone, but also to have as a goal and as a north aligning with the reference method that the CDC had available for us to work with. And Leslie is going to tell us more about her journey developing this assay and the data that she's obtained in this assay that is clinically implemented in our laboratory.
Okay, so as Dr. Colon-Franco mentioned, we're going to build off of this foundational method that we made. We spent a lot of time up front to make sure that it was accurate. We knew we were going to be able to see the low end that we wanted in spiked matrix, so that gave me additional confidence. We're also expecting a high sample throughput. We wanted to use an identical extraction procedure just to keep things streamlined for the bench. We knew we wanted to measure direct just based on the inaccuracies of some calculations, and as most labs are going to, we wanted to make this automation facing. So technical challenges, everything that you would expect to encounter for total, you're going to encounter for free, except the stakes are higher because the signal is lower. Losing signal intensity is a big thing that we battle a lot. It's one thing to get the signal that you need, but then maintaining that signal is a whole different ballgame. So if we're just comparing the two LOQs between total and free, total being on the left, if you lose half of your signal for that LOQ for total testo, you're fine. You can still quantitate, provided your internal standard is also within line. But if you're losing signal for the right, the free, that absolute area is, just over 10,000, and that's something that we struggle with. So for free development, we knew we had our extraction procedure. I was able to see the LOQ and spiked matrix, so we were going to evaluate ultrafiltration and dialysis. So ultrafiltration is an alternative method, dialysis being the gold standard, so we explored both of them, and ultimately we implemented dialysis. So ultrafiltration can work for many labs. It requires a large sample volume to get the filtrate needed to produce the signal on the back end after extraction. Single devices per specimen was a big stopper for us just based on that sample volume. So if you consider a centrifuge and you have, a rotor with specific angles and a device, perhaps being very tall, you can only fit X amount of those devices in one centrifuge. And if you're expecting to get 100 samples a day, that's just not feasible for the lab. We also encountered inconsistent device performance, which probably could have been worked on, just fine-tuning some things, but we knew that this method wasn't going to work for us because ultimately it was not automation friendly, and we weren't going to be able to sustain that throughput. We would need tens of centrifuges to do that. So when we're looking at dialysis, we had several things to consider. What type of device are we going to use? What buffer? We learned that the sample to buffer ratio is critical, and there are also different dialysis parameters. So this was a publication made by the CDC where they evaluated several different dialysis devices. Harvard Apparatus is one of the early developed devices. Scienova has a few, and then Thermo offers the red device. We ultimately went with the Thermo red device, and some of the considerations that we made there were the device design, the ease of use, and the ability to implement automation going forward. So several of the devices that we tried, they have this chamber. So this chamber is open to the buffer, and there's a lot of surface area to interact with the buffer, which is really nice. Some of the other devices that we looked at were sort of the membrane was encapsulated in like a little cage, so there was less opportunity for interaction. Also, the tube construction with orbital mixing really gives you a lot of interaction there and can help with the amount of time you need for dialysis. We also needed to look at dialysis buffer. There's really two main ones, phosphate buffered saline and HIPS buffer. This is a table that we used early on in method development. We looked at different devices with the different buffer using specimen pools. We ultimately went with the HIPS buffer. It offered less variability between even the HIPS buffer performed better with both devices, and so we went with that. It's more consistent. It did align with the CDC method, and if your ultimate goal is to be harmonized with a reference procedure, it would make sense to just go ahead and use that. But doing our due diligence, we wanted to evaluate the others. And we were also able to perform some in-house stability experiments, and the pH buffering capacity and just the pH stability in hips over time was much better for the workflow. So the lab will only have to pH up front once a week, and then we can store that into single aliquot containers that can be pulled the day of dialysis, and that also helps with contamination because you're not using the same product over and over again. You're not pulling it out of the fridge, putting it back, and things like that. So sample to buffer ratio is critical. We were relying heavily on the gold standard reference measurement procedure with the CDC. Each device is going to come with an IFU, and they're going to give you some different volumes that you could play around with. These are suggestions. And this is also device dependent. So some devices you can get pretty close to a 1-to-1 ratio of sample to buffer. Others, there's quite a disparity there. So if we look at device A, we tried a couple different sample to buffer ratios, and device B, we sort of repeated that activity. The less you can dilute and the closer you can stay to that 1-to-1 ratio, we found you get more consistent results, and you'll also get more harmonious results with other laboratories. So we ended up going with device B because that offered a smaller dilutional volume between the buffer and the serum sample. So dialysis, how long, what temperature, things like that. There's so many ways you can evaluate it, and we did multiple time course studies with multiple devices, sometimes going out to 28 or 48 hours. And this is an example of a time course study that we did early on with male patient pool. You can kind of see that the concentration is leveling out around 5, 6, 7 hours. So between the 4 to 7 hour mark, we're seeing standard deviations for concentrations at 0.5 and like a CV of less than 10. So we were happy with that. We did additional studies using single sample specimens and pools. We were able to determine that there was no statistical difference between the 4 to 12 hours for dialysis, but ultimately we went with an 8-hour dialysis time just based on the workflow and the lab and the shifts that we have. So that's something to consider if you're gonna roll out free testo in your lab. What's your lab capable of? Timelines and things like that. If you're going to take your dialysate samples earlier when there's a higher rate of change, you're going to have to hit that time point a lot more. I would say it's a very rigid time point. Taking it at the 8 hours gave our techs a little bit of a buffer, so they don't have to feel so pressured to start pulling samples at a certain time. Okay, so altogether, we've worked on the isolation. Our samples will get pre-treated, they'll be extracted, and then they'll be submitted for analysis. So this is a diagram just demonstrating the assay workflow. So for free testo, we obviously need to go through equilibrium dialysis. And again, we're using the thermo red plate. So we have red top serum that's added to the red chamber. That's another consideration for the lab. That's very obvious that that's a serum chamber. And then your buffer is added to this white buffer chamber. They will go through dialysis for 8 hours at 37 degrees C. That's just your body temp. And we do like gentle orbital shaking. Another consideration is the format of the dialysis device. A lot of the vendors will offer single-use devices. You can use a plate. They can have plates with inserts. This is a 48-well format. So if you're running 100 samples, you're going to need to put up 2 dialysis plates. So that's double the blanks, double the QCs. And this is our standard plate format that we have now in the lab. And at the bottom, We've left some recovery chambers just in case somebody missed pipettes. We won't have to wait till the next day. We can, keep it on the batch for today. So after we go through dialysis, we're able to pipette out the dialysate, and that will get pre-treated. This is where the workflows come together. So we have a single serum sample that will go through equilibrium dialysis for free testo. That same serum sample will be aliquoted into a pre-treatment plate for total testo. So the volumes vary a little bit, but ultimately the extraction is the same. So we are using sample aliquot for either your serum or your dialysate, and those are just different volumes. We're going to add our internal standard. I'd like to note here that we're using the same internal standard concentration, same internal standard solution, and this also helps the bench. We prioritize single-use aliquots to really reduce the chance of contamination, and it's just a little easier to not have to keep track of one bottle. You have a rack of things that you can use, and if something were to happen, if you spill something, you can just grab another aliquot. It's not like you have to make a new internal standard solution. So after we add the internal standard and we acclimate the IS with the sample, they get diluted with water. I know that seems counterintuitive. Why would you want to dilute free testo? But this just allows the sample to fully interact with the SLE media, and you really want that to happen because it's going to kind of attract the phospholipids and things like that, and that's going to give you a cleaner sample at the end. So after they're diluted, they're immediately loaded onto the SLE media, which is just diatomaceous earth. They're equilibrated there for 5 minutes just to let everything sort of glom on, and then we use the same exact procedure for total and free, where we'll extract with 3 elutions of hexane and ethyl acetate. After that, the plates get dried down at 40 degrees C, and then we're reconstituting in the same solution, just different volumes. We're reducing the volume for free testo because we want to get that signal boost, and then they are analyzed ultimately on a triple quad thermoaltis scarlet, who's very dear to my heart. This is an example of our gradient, which we're able to achieve separation of the isobars and adequately wash out any additional matrix to be clean for the next injection. This is a summary table for our validation performance of free. We were able to achieve the 0.1 nanogram per deciliter LOQ. Again, the signal is something that everyone, you should be concerned about, keeping the system clean, keeping your signal up. We were able to compare to a reference lab with a mean bias of 10%, which was great. I'm very proud of that. And I'll show some chromatography examples. So we are using a cent for quantitation here. So sequentially, we're looking at a blank sample, our LOQ, and then our high-level calibrator, and I'm just highlighting the difference in the height. Getting reliable signal and reliable quantitation at that low level is imperative, and having your blank be truly blank is also imperative. We deploy several different types of blanks, so for free, we're going to look at the HIPS buffer itself. We always evaluate the device itself, so the chamber, and then we'll also vet the SLE media, just running the LUN through that, and those all need to be blank for this run to pass. And that just ensures that we're not getting any carryover signal or just intermittent signal that might not actually be testosterone or something that's contributing from one of our consumables, and that will eventually help us trace things back to a root cause if need be. So again, the CDC offers several different programs for standardization of hormones. They're not going to do that for free, just based on the amount of labs that are offering direct measurement of free. But we were able to participate in their interlab, and as you can see, it's quite the gamut, the range of performance. The calculated tests are typically biased high. Direct measurement is better, and I'm very proud to say that we are Lab D with a very, very small bias with the CDC, and that was with their help and guidance and just talking through with other labs. What are you doing, what's working, and how can we come together and just make this as quality as possible. I'd like to also present an example of our workflow. So method development is not linear at all. I'm sure everyone here knows that. So you really need to think about how your assay is going to impact the lab. Like, is it doable? Are we going to stress people out? So I'm fortunate, and we're fortunate enough to have 7 techs that are trained on this assay, 4 first shift, 3 second shift, that work really well together. They understand that what they put in affects the next group, and the workflow that we rolled out, because it's an 8-hour workflow, we knew it was going to go across shift. We don't have 10-hour shifts, it's just 8 hours. So first shift will ultimately build the batches. They're going to start the dialysis, then they'll be able to start their total extraction. And the extraction time total, once you aliquot, is like probably around an hour, hour and a half, so that's pretty quick for the clinical lab. While they're drying down, and we nailed this down during training, I'm like, this is what we're doing, this is how this is gonna work. We looked at queuing SST during dry down. After they queue their SST, they can take a break, come back, evaluate the SST, and then they can start their total batch. So the total batch is going to be running, second shift will come in, we have standardized plate maps. This is how they communicate with each other, letting each other know if there's a position change, if they need to fix that in the batch later. And then second shift will extract free and ultimately put that on to run. So the workflow, we could probably tighten it up a little bit, but this is working really well with like the nice 8 hours. We have a little bit of a buffer time either way. And yeah, I think we're doing all right. So there are several unmet needs for free testo. Technical, we're always looking to improve signal to noise, just throughput in general. As as the orders go up, we need to start thinking about automating the workflow, because the second you add samples and you're spilling over to maybe another plate, that's additional tech time, additional chance for contamination. So automating this would really be helpful in that and reduce repeats and quality oversight. So the CDC won't be offering that accuracy-based proficiency testing for free testo. But there's a lot of room, I think, for collaboration in the future with other labs to maybe come up with a consensus on, how we're going to standardize with each other, because ultimately that's the goal. We want to give quality data for patient care.
This is really our last slide, where we're highlighting, number one, that we have the win, we did it, right? So we developed that method that we could use the same principles of the total testo assay to measure free testo assay with our instrument, with our manual capabilities, but there are vulnerabilities that we have intrinsic to us, our volumes, and also intrinsic to the concern about losing signal, etc. So the need for perhaps becoming more robust in the future. But we're very excited that with this method we have several opportunities to work on outcome studies using our reference method. There's opportunities to improve and revisit calculations and maybe offset some of this testing to calculations that are aligned with the RMP, harmonize reference intervals and cutoffs, and ultimately work on what is the patient that will benefit from this testing. This work was supported by a lot of people that work, so we want to acknowledge the contributions